Hello friends, Dr. Kazmi once again, and today we are going to talk about the basics of pediatric mechanical ventilation. These days, in the context of COVID-19, there has been a lot of emphasis on intensive care treatment for those people who have been severely affected. And therefore, I thought that it would be a good idea to give you some basic information about mechanical ventilation. Since I'm a pediatrician, I would focus my talk on the pediatric mechanical ventilation, but nevertheless, the principles are the same and they apply to adult medicine as well. So let's start with the outlines of this talk. And in today's lecture, I will start with some basics of mechanical ventilation. I will try my level best to keep it as simple as possible, giving you some idea about what are the differences between oxygenation and ventilation. How do we control each of these parameters in the breathing cycle? What are some of the basic ventilation parameters and ventilation modes? And we would talk about some clinical uses. Now, I'll be trying to keep it as simple as possible. As far as the advanced mechanical ventilation is concerned, I will discuss it in my coming lectures. So let's start with some basic difference between the mechanical breath and spontaneous breath. So remember, normal breathing pattern, the normal breathing that we are doing all the time, that is always initiated by a negative pressure. So whenever you are breathing, the inhalation cycle is actually initiated by the negative pressures inside your thorax, and that actually then invokes the intake of air inside the lungs. Well, that's quite different in the mechanical ventilation, because in mechanical ventilation there are no negative pressures. So you are taking over the physiology of the affected person, and the breath that is delivered by the machine is actually initiated by some form of positive pressure. So you are actually pushing the breath in. Now, you should understand some of the basic parameters in breathing, and there are two parameters that we always talk about. One is oxygenation and the other is ventilation. And I will give you a very simple formula of 2 by 2 that you have to remember. For oxygenation ventilation, there are two basic parameters that we always deal with, and that would make it quite easy for you to understand as well as remember those parameters. So first of all, let's talk about oxygenation. So oxygenation basically deals with maintaining of your normal oxygen levels. A breath cycle consists of inhalation and exhalation. So when we inhale in, the oxygen in the air goes inside and then it traverses the alveoli and gets into the blood. This process is known as oxygenation. So oxygenation basically is dealing with maintaining the normal blood oxygen levels. Now, if there are problems with the low oxygenation levels in presence of a normal carbon dioxide, we call it as type 1 respiratory failure. So remember, type 1 respiratory failure deals with low oxygen levels in a setting of normal carbon dioxide levels. Now, ventilation is a term that we use for dealing with carbon dioxide. So in fact, ventilation is dealing with maintaining of normal blood CO2 levels, and the normal blood CO2 levels are 35 to 45 millimeters of mercury, or if you use the other units, the Pascal units, then it is 4.5 to 6. Now remember, ventilation problems deals with high carbon dioxide levels, and we call that as a type 2 respiratory failure. So type 2 respiratory failure can have a normal or a low oxygen level, but the basic pathology in a type 2 failure is high level of carbon dioxide in the blood. So you would be having more than 6 kPa or more than 45 millimeters of mercury of carbon dioxide in your blood sample. Fine. Moving ahead, some of the basic concepts, as earlier we discussed oxygenation and ventilation, and by now oxygenation deals with maintaining oxygen level in the blood, and ventilation deals with maintaining carbon dioxide levels in the blood. Now, the rule of two says that oxygen level maintenance in the blood, actually there are two things by which you can know whether the oxygenation is normal or not. So the first is the what we call as the saturation levels at room air. So oxygen saturation at room air should always be greater than 92%. The other thing that which you can determine to know if the oxygen levels are normal in the blood or not is by doing an arterial blood gas, or in kids we do a capillary blood gas. So depending on the unit that you use, the arterial level of oxygen should be greater than 60 millimeter of mercury or greater than 8 kPa. Now, for ventilation carbon dioxide uh, issues, again, there are two things by which we can say. Number one is pH. So, capillary blood gas sample or a venous blood gas or arterial blood gas, pH can tell you whether there's any problem with the carbon dioxide or not. So remember, whenever there is issues with carbon dioxide, if the carbon dioxide levels are too high because of any issue with your lungs, the pH would go down. So the pH would be less than 7.35. Normal pH is 7.35 to 7.45. An acidotic pH that is less than 7.35 in presence of a lung pathology means that you have problems, issues with ventilation. The other thing is by looking at the levels of carbon dioxide in the blood sample. The normal carbon dioxide levels are 35 to 45 millimeters of mercury or 4.5 to 6 kPa. Now, if the levels of carbon dioxide are more than this level, it means that there is some issue with ventilation and the body cannot properly get rid of the carbon dioxide, and we have to find the reason for that and then fix it. Now, coming down to some of the terms that we use in mechanical ventilation, and again the same 2x2 formula applies. So again, as I said, there could be an issue with oxygenation or maintenance of oxygen levels in the blood, or there could be an issue of maintenance of carbon dioxide levels in the blood. And there are two parameters which actually determine your oxygenation level in the blood, which you can actually titrate on a mechanical ventilator. And as far as oxygenation is concerned, the first one of them is FiO2. So that actually stands for the fraction of the inspired oxygen in your breath. The normal air contains 21% oxygen and 79% nitrogen. So that's the normal concentration. Now, when we are giving breaths through a machine, that is the mechanical ventilator, we use higher levels of FiO2, which go anywhere above 21% to 100%. But the lung protective strategies actually determine that we should be using low levels of FiO2. So we should be using as much close to the physiological FiO2 that a person uses. So we should be actually using somewhere around, let's say, you can use anywhere from 24 to 50-60%. But high levels of FiO2, though you can use it for a short period of time, in the long run they are always toxic to the lungs, and they can induce lung injury like fibrosis or pulmonary hypertension. The other thing is the mean airway pressure. So if there is some problem with the oxygenation, you can push the breath with a force. So the more forceful the breath is, the more oxygen would be pushed inside, and it would be easy for the oxygen to diffuse inside. So oxygenation level depends on titrating your FiO2 levels and mean airways pressure, which again there are certain indicators by which you can adjust the mean airways pressure on a mechanical ventilator. Now, as far as ventilation is concerned, the carbon dioxide levels, if your body has got high carbon dioxide levels, it can be adjusted by adjusting the VT, which stands for the tidal volume. So tidal volume is the amount of air that is pushed inside with every breath, and the other is the respiratory rate. So respiratory rate is the number of breaths that a person takes per minute. So together, respiratory rate multiplied by tidal volumes equals your minute ventilation. So you're adjusting the minute ventilation actually adjusts your carbon dioxide levels in the body. Now, coming to some basic parameters which are set on a mechanical ventilator. If a child is intubated and put on mechanical ventilator, so there are certain dials on the mechanical ventilator that need to be set. And with modern ventilators, there are so many things that can be played around, that can be titrated to give you the best settings for any given condition. But nevertheless, there are a few basic things that you need to understand. So FiO2, as I said, that stands for the fraction of the inspired oxygen level. So normally, I mean, when we start intubating, because always there is some severe reason for intubating a child. Definitely there will be either acute severe asthma, or there will be acute bronchiolitis not responding to vapotherm, or let's say there is a neonate with acute respiratory distress syndrome, or there's some other pathology like a child with Guillain-Barré syndrome who is not able to breathe properly. So in that case, we usually start with high FiO2s. Normally, I mean, because in rapidly induced uh, intubation, because the child has been apneic for some time, so we usually start with 100% oxygen levels. But with the passage of time, we have to titrate it down. So we would be titrating it anywhere between 40 to 60%. So we always start with a high FiO2 level, and we gradually go down and see where we can maintain oxygen sat somewhere around, we would say, like 88 to 93, 94%. You don't have to go for 100%. You can be, you can be a bit conservative. So around 93, 94, one should be happy with those sats levels. Respiratory rate. So the other dial that has to be set is the respiratory rate. Now, normally, respiratory rate has to be adjusted as close to physiological respiratory rate that is normal for that age group. So, for example, if you are intubating a neonate, the neonate can have a respiratory rates of up to 50, 60. So definitely you can set it anywhere 30, 40. Similarly, if a child is, let's say, if you are intubating an adolescent, then probably you should be happy with a rate of, let's say, 12 to 14 breaths per minute. So respiratory rate should be adjusted as close to the physiological rate, which is normal for that age group. Then the third thing that you need to adjust is the tidal volume. You should understand tidal volume. Normally, this is the dial that we set in, especially when we are putting a child on assist control. And tidal volume is the amount of air that is pushed with each breath. So whenever a child is inspiring in and the ventilator pushes the breath in, so that would be the amount of air that goes in. Now, tidal volume in children, we keep it anywhere around 4 to 6 mils per kg of ideal body weight. Now, please keep it in mind that this is the ideal body weight, which is determined by the height of the child, because kids can have different body weights. So let's say a child who is 3 years of age, a malnourished child might be having a weight of, let's say, around 6 or 7 kg. On the other hand, a very healthy child might be having a weight around 15, 16 kg. So there is a lot of difference. So you cannot use the actual body weight, because then it would be giving you a different tidal volume. So we have to use the tidal volume which is based on ideal body weight. And remember, ideal body weight is always determined by the height of the child. So you have to take the height of the child, and then there are formulas by which you can calculate the ideal body weight for that particular height, and then you multiply it by 4 to 6 to get the tidal volume. So that has to be adjusted in that way. The next thing is IE ratio. That stands for inspiratory to expiratory ratio. Now this has to be, because every breath has got some time for inspiration and the rest of the time for expiration. Now normally the general rule is that we would keep an IE ratio of 1 to 2. It simply means that if a breath has got a time limit, one part of that time is actually reserved for inspiration, while 2 parts of that time are actually reserved for expiration. So the normal ratio is 1 to 2. But sometimes in certain conditions in which there is, let's say, excessive accumulation of air inside the lungs, like expiratory pathologies like in acute severe asthma, where the child is not able to properly exhale out and there's air trapping inside the lung, we usually go for a higher IE ratio. So we can have a 1 to 3, maybe sometime 1 to 4, and in severe cases even 1 to 5 ratio, inspiratory to expiratory ratio. But nevertheless, if there is no air entrapping based on your lung x-ray, things like, you can go for 1 to 2 ratio. Then PEEP. PEEP stands for positive end expiratory pressure. Now normally, if there is some alveolar pathology, some of the alveoli are working and some of them are not working. So what happens with every breath, the alveoli, they pop open, and then as the child exhales out, the alveoli, they are shut down. So there is a lot of shearing forces on the alveoli. Some of the alveoli are completely collapsed, they are not being open. So we need to put some pressure, constant pressure inside, even at the end of the expiration, so that these alveoli, they are kept open. That actually prevents these alveoli from these shearing forces, and there would be less alveolar damage. So we call it as a sort of a lung protective strategy. So there should be some form of PEEP. Normally PEEP in a normal lung, it should be somewhere around 3 to 5 centimeter of water, but to start with, we always start with 5 centimeter of water. So what happened, this 5 centimeter of water actually is the pressure even at the end of the breath, and this pressure is keeping the alveoli open. So what happens, with every breath, more and more alveoli are recruited. So if we have to recruit more alveoli, those alveoli which are not working and contributing to what we call as ventilation perfusion mismatch, then we have to give some PEEP, and that PEEP would keep the alveoli open. So it is a very important concept that we should understand what PEEP is, and how to adjust PEEP, and understand its role in keeping the alveoli open, recruiting the alveoli, and actually improving oxygenation. And then the mode. There are different modes. I would start with some very basic mode. So mode is actually it tells the ventilator whether the ventilator is fully supporting the breaths or whether it's partially supporting the breath. Then again, whether it is primarily working by giving the child a set volume, or whether it is supporting the breaths by giving a preset pressure, or is it simply allowing the child to breathe on its own, and wherever needed it just gives some extra support to the breath. So depending on the condition of the child, depending on the underlying condition, we can have an AC mode, which stands for assist control. We can have a PC mode, which stands for pressure control. We can have a PS, which stands for pressure support mode, and we can have some mix mode like SIMV, which stands for synchronized intermittent mandatory ventilation, in which the child is spontaneously breathing, but at the same time you keep a mandatory number of breaths. So in case if the child is like, if he's not breathing, then the machine takes over and delivers some breath, and if the child is actually taking spontaneous breath, it would give it a little bit of push to help in the breathing. And again, then SIMV can be having like some form of pressure support, it can have some form of volume support, and then we have got some other forms of modes as well. I would talk about these modes in my next lecture in detail, but for the sake of simplicity, just to let you know, a child who is completely, let's say if you start with intubation, definitely you give a general anesthetic to the child, he's completely knocked out, you put him in deep sedation, you have used some form of paralysis, so this child cannot breathe on his own, so he's, in other words, he's dead. So the machine has to take over. So the machine has to give all the number of breaths. So let's say if you are giving him 20 breaths, all the 20 breaths have to be given by the machine. If you set a particular volume, then that volume would be delivered. If you set a particular pressure, then in every breath that pressure would be given. But what I'm trying to emphasize is that all these breaths would be given by the machine. So it is a completely controlled mode. That's why we call it as assist control or pressure control. So the machine is controlling all of the breaths, the machine is controlling the body, and it is either controlling by controlling the volume of the breaths, or it is doing that by controlling the pressure of the breaths being given. So AC and PC are some of the common modes that are used in the beginning of mechanical ventilation. And once as the child is improving, then you can go on the other modes like synchronized intermittent mandatory ventilation with some pressure support, or that is usually used when the child starts doing some breathing, sedation level is being reduced. So you give a trial, and you see if the child is having some spontaneous breathing, then you can prepare the child for weaning and for extubation. Fine. So moving on to some of the modes of ventilation. As I told you earlier, we can have the assist control, we can have the pressure control, and we can have some mixed modes. Now in assist control, I told you earlier that what we do is basically we set the FiO2 level, that is the fraction of the inspired oxygen level. We set the tidal volume. The tidal volume is the amount of air that will be pushed in every breath, and that is around 4 to 6 mils per kg ideal body weight. We also set the respiratory rate, and we also set the IE ratio. As I said, tidal volume should be 4 to 6. Males of ideal body weight respiratory rate should be as close to the normal physiological respiratory rate for that age group, and IE ratio is usually 1 to 2. In most of the lung pathologies, in severe air obstruction, it could be around 1 to 3, or sometimes you can go more depending on how the child responds to the initial IE ratio. So what you, as you said all these things, the ventilator then the sets pressure. So you have set the volume. Now in order to deliver that minute ventilation, what the ventilator would do, the ventilator would generate the pressure. So whatever pressure is necessary to in order to deliver that tidal volume, the ventilator would go for that. So the pressure would vary while you set the tidal volume and the respiratory rate along with FiO2 and inspiratory to expiratory ratio. And pressure control, it's the opposite. In pressure control, you set the pressure and you set the PEEP along with FiO2 and IE ratio. And what the ventilator does, the ventilator would adjust the volume of the breath to be given. So the ventilator is actually setting the tidal volume. So you are setting the pressure and the PEEP, and then in order to deliver to maintain that pressure, whatever volume has to be given, the ventilator would generate that and would give it to the child. And then, as I told you, that there are mixed modes that uses different methods. They can either give some form of pressure support. You have got some mandatory ventilations which can be either volume control and pressure control, and then it just gives, if the child is also having some spontaneous breathing, it will just give some form of support to it as well. And we've got some other methods as well, which I would be discussing in my coming lectures. Fine. Now, usually the question which is usually asked to us is like, which ventilation modes can be used in different conditions. Now, people have got their favorites as well. It depends on I would say it depends more on the patient condition and the underlying diagnosis. But as a general rule of thumb, what I have seen that pressure control is preferred in neonates, and for young infants and older. In young infants, you also preferably you go for pressure control, while older children and adolescents, you usually go for volume control, assist control. Mixed mode, the SIMV with pressure support or volume control, they are usually used as weaning methods before weaning a child off from mechanical ventilation. But remember, irrespective of the mode, it is mandatory. It is very important that you should be continuously monitoring the child in terms of their hemodynamic parameters for every intubated child, because they can go either way. Remember, because you are taking over the physiology of the child, it's very important you are looking at all the blood parameters. So along with the full blood count and the routine chemistry that you do every now and then, it's very important that a child who's intubated is regularly monitored, and especially arterial blood gases should be used every now and then to see that the pH, PCO2 and PO2 are within the normal limits. If something is not going fine, then you can tune these things like FiO2, like PEEP and things like that to either improve the oxygenation or improve the ventilation. It's also very important that child who's been kept on mechanical ventilation, they should be having regular tracheal suctioning to clear up the any mucus secretions inside the respiratory tree. Tube position, checking the tube position is very important because tubes can dislodge. They can go in the right main bronchus. They can get kinked, and also you have to check the need for sedation because if a child is deeply sedated, and definitely the machine has to do all the work. But if you are trying to wean off the child, then the sedation needs to be lowered to see that the child starts spontaneous breathing or not. And it's also mandatory to do some radiological evaluation by doing chest x-rays to see if the underlying pathology is clearing up or not. So as general indications for mechanical ventilations, a child who's got acute respiratory failure because of any underlying pathology like pneumonia or anything, you usually start with assist control. If a child has got acute respiratory distress syndrome, we usually go for pressure control strategies, or if there are acute obstructive pathologies, we can start with pressure control. So again, it depends whether the child has got underlying type 1 respiratory failure or type 2 respiratory failure, and what do you want to achieve. So there are no hard and fast rules. You can use any combination of that. But as I said, as a general indication, if there is respiratory failure, you will start with assist control, and if there is respiratory distress syndrome, you'll start with the pressure control strategy. And last but not the least, it's also very important how do you tune these different settings on a mechanical ventilator depending on your ABG findings. So let's say you have started a child on assist control, and you have intubated you've already intubated the child, okay, and after some time, after half an hour, you do a blood gas and you find difference. So let's say if you have got low oxygen levels, if you have still the child has got low oxygen level or has got low sats, O2 sats, so then what you can do is you can play around with FiO2. So you can start increase, but normally if FiO2 is already on its maximum, then the other thing is that you can play around with the PEEP. So let's say if the child has you started with the PEEP level of 5 centimeter of water, you can dial another value, you can go up to 8 and see whether it leads to any improvement in the oxygenation or not. If the oxygen levels are normal with whatever settings you have used, then it's the best thing is if they were like sort of conservative numbers that you were starting with, you would continue with that. But let's say if you started off with the high levels, let's say if you had a high positive inspiratory pressure, you would titrate it down to see where you would be maintaining normal O2 levels. If the PEEP has been high, let's say your PEEP was 10 and the oxygen levels have come down, so after some time you will titrate it gradually in small increments. You will titrate it down to see what happens with the oxygen levels. Similarly, if you started off with high FiO2 levels, you have to titrate it down, because I said like high FiO2 levels for over a prolonged period of time are not good. They are actually quite toxic to the lungs, so you have to go down to some acceptable levels, somewhere around 40% to 50% oxygen. If the tidal volumes have been high, you would decrease if it was already high. With a high CO2 level, if you've got high carbon dioxide, that means problem with the ventilation. So ventilation, as I told you earlier, depends on two parameters, that is your tidal volume and your respiratory rate. So if there is high carbon dioxide levels, like the CO2 is high, or let's say the pH is low, then you can increase the respiratory rate or you can increase the tidal volume. Tidal volume, you have to be a bit careful with the tidal volume because the lung protective strategy says that you should be using a low tidal volume. So as I said earlier, we will start somewhere around 4 to 6 mils per kg of the ideal body weight. You can increase it, but I think increasing it above 8 mils is usually not a good idea and can damage the lungs in the long run. So the other parameter with which you can play around is the respiratory rate. So you can increase the respiratory rate, and that will blow off the carbon dioxide levels, and the pH would start coming back into the normal limit. If you've got a problem of low CO2, it means probably your ventilation is quite high, so you need to tune down the ventilation. So you can either decrease the tidal volume, or you can play around with the respiratory rate. You can decrease it to bring the CO2 levels up. But sometimes even with playing around these values, we are not able to control oxygenation levels or not control ventilation. And if the patient is not improving despite tuning these ventilator settings, then we can use some other strategies, like we can use inhaled nitric oxide. We can use proning position, which is usually done in ARDs. We especially do it in adults, especially in the settings of COVID-19. But it's very difficult because if you prone a patient who's been intubated, there is the chance that the ET tube may get dislodged, it may come out, so one has to be very careful while doing proning. Similarly, we can use steroids as an adjunct therapy in children sometime who are not improving. We have got two very good other strategies. One is the high frequency oscillatory mechanical ventilation, in which we use very small tidal volumes at a very high rate, and they are quite safe, and they improve oxygenation as well as ventilation. While those who are not responding to it, then the last step is ECMO, which stands for extracorporeal membrane oxygenation, in which you can do a veno, like you have to take the blood out, remove the carbon dioxide in a machine, and then put oxygen in, and then bring it back to the body. And then in other words, the machine is taking over the function of the lung till the lungs are able to perform on their own. So these are some of the principles of playing around with the ventilator settings. for normal or high carbon dioxide and oxygen levels. In my next lecture, I would touch on these things in a bit more detail and tell you what are the different conditions and how we play around with these settings. So I hope you have understand this very basic things about mechanical ventilation. Although I have touched basically these things in context of pediatric, but nevertheless the principles are the same for adults as well. So if you've got any questions, please do ask me in the comment section below. Do subscribe to my channel. Thank you very much. Bye bye.